Morning, Rebecca, Eric, and Dr. Rawson.
Albert, how are you?
I'm well. How are you?
No, I started taking prednisone today, so
Oh, okay.
hopefully I'll be better.
Yeah. Yeah, I hope
Just
that
sending
will.
you an email. Tom's doing grand rounds tomorrow if you're interested.
Oh, really?
Yeah, on the history of the addiction workforce.
Oh, well, that's interesting.
Yeah, I hope he does a good job. I think I'm going to try it. It's at 2 o'clock my time, 11 o'clock your time.
Oh, okay. Oh, very cool.
He asked me for slides. I don't really have any slides on that topic. Although it's an interesting topic. I hope he does a good job.
I attended I presented on that one time, probably within the last 6 years, I think,
Really?
on the turnover and the challenges that, that there's really no career ladder for people
Right.
who, I mean, and so basically what they do is they leave for another company so that they can get a
Right.
promotion and get additional resources and stuff.
I think he's going to do stuff on the history on how the addiction workforce ended up being so different than the mental health workforce.
Mm.
And
Oh,
that'd be interesting. I've never heard, I mean, I know basically the story, but I've never really heard, and I don't know anything about the certification boards and all that. Well, we better shut up. We're going to start right
all
away.
right. Talk to you soon.
Yeah, bye.
Brick leg.
Good morning, everyone. I am Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Stimulant Use Disorder Webinar Series Part 1 with Dr. Richard Rawson. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the upper or lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you are experiencing poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and use the call-in option at the top of your screen. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADAA's website within 30 business days after the event. To access the recording and PowerPoint, go to www.fadaa.org, then to our Resource Center, and then to our training library. FADAA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credit earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will first need to register or sign into your account to complete the evaluation. Information as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access the statement of credit. Please note that the evaluation will close Friday, March 25th. Up to 1 continuing education credit is available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. And now I'd like to present our presenter today, Dr. Richard Rawson. He is a professor emeritus at the University of California, Los Angeles, Department of Psychiatry, and research professor at the Vermont Center for Behavioral Health at the University of Vermont. He received a PhD in experimental psychology from the University of Vermont in 1974. Dr. Rawson conducted numerous clinical trials on pharmacological and psychological behavioral addiction treatments for the treatment of individuals with cocaine and methamphetamine disorders. He has represented the United States in numerous meetings on methamphetamines. He has led addiction research and training projects for the United Nations, excuse me, the World Health Organization, and the U.S. State Department, exporting science-based knowledge to many parts of the world. He currently is providing consultation on treatment of stimulant use disorders to 8 U.S. states and several international projects. Dr. Rawson has published 3 books, 40 book chapters, and over 250 peer-reviewed articles, and has conducted over 1,000 workshops, paper presentations, and training sessions. Also joining Dr. Rawson today is Mr. Albert Hassan, who will be interjecting today as well and presenting. And now I'd like to turn the presentation over to you.
Thank you very much. Yeah, I really appreciate the opportunity to talk with you today. It's been great to, we had a previous session, and we'll have one more after this on stimulants that we're presenting to groups in Florida. And I really do appreciate the fact that the state has decided to provide this information, because as I hope I can make the point to you, the issue of stimulant use and stimulant use disorders are playing an increasing role in the overdose crisis that we're seeing in the United States. And although, you know, in many parts of the country, we have seen some improvements, or we started to see some improvements in reductions in overdose deaths toward the end of the 2018, 2017, 2018, 2019, in some parts of the country, the combination of the pandemic and the increased availability of fentanyl and the mixture of fentanyl into the cocaine and methamphetamine supply have really produced a real urgent crisis in overdose deaths. So I think it's really timely to get some good information out about stimulants. For many of you, unless you've been sort of in the field as long as I have, or 20 years or plus, you may not have that much exposure to the most current information on stimulants, particularly methamphetamine. I know Florida has a significant methamphetamine problem, but in relative terms, compared to the West Coast and the Midwest, it's a more current problem. You've had a longstanding problem with cocaine for sure, and so we know you have experience with these individuals using these drugs, and hopefully, though, I can give you some material that is help you with have greater knowledge around specifically around methamphetamine, because that's the one that's showing the biggest increases and is the one that's most associated with the increase in death rates with and without fentanyl. And so these are the objectives of today's presentation. And I'll start with the issue of epidemiology of what we're currently seeing on the street. Now, all epidemiology data has a lag time, so I can't give you data for the first 3 months of 2022, but I can tell you what the data are and what the data look like through 2021. This is a NIDA slide that comes from the National Institute on Drug Abuse and goes through 2019. And this really is a great overview of the whole overdose death crisis in the United States over the last 20 years, which you've been a major, Florida has had a major involvement in this. Certainly the yellow line, which starts to rise in the early 2000s, which represents prescription opioid overdose. That's when we started seeing the increase in OxyContin deaths and other prescription medication deaths. Those deaths leveled off in about 2010, 2011, as restrictions started to be put on the availability of prescription opioids. However, if you notice, as those leveled off, the green line starts to go up. That's heroin deaths. That went up for about 5 years and then leveled off. And then most recently, 2015 and on, you see this huge spike in the red line, which is fentanyl-related deaths, and in the blue line, which is stimulant-related deaths, combination of cocaine and methamphetamine. And the last point on the slide are the data from 2019. If you were to extend those data into 2021, they accelerate dramatically. It's almost a straight line up for both of those drugs. Prescription opioids, heroin, are still at a relatively similar rate as they were for the last 10 years. But fentanyl and stimulants are really the major contributors now to the overdose death problem. And before I forget, because I do occasionally forget to make this point, Al and I worked together. Al Hassan, who will be the other presenter in these sessions, worked together for 40 years in California at UCLA. Now, California had all of these epidemics, very bad cocaine epidemic in the 80s, methamphetamine emerging in the late 80s and through today, and of course the opioid epidemic. We spent much of our time in the 80s, 90s, and first decade of the 2000s addressing methamphetamine. We wrote something called the Matrix Model, which was an outpatient treatment protocol. And we did lots of studies on medication treatments and behavioral treatments for people with methamphetamine use disorder. All that time, we were doing that work during that 30 years or so. When we would do talks on methamphetamine and cocaine, we would rarely talk about overdose deaths. That was relatively rare to have people dying of stimulant overdose during those earlier years. That's not at all rare now. It's and I think that the point I want to make with that is, as you work to treat these patients, you have to realize they're at very high risk for death. If they get into treatment, that's a safe place, or a much safer place for them than being out of treatment, whether it's inpatient treatment or residential treatment or sober living or whatever kind of treatment. Being in treatment reduces your death rate by about 3 times. So if you get people into treatment, people who use stimulants, don't kick them out of treatment. Find some other way of expressing your displeasure with their behavior, but kicking them out of treatment is in many cases a death sentence. It's no longer like it was when I was treating patients. If patients dropped out of treatment, you assume they would cycle back and you would see them at a later time as they went back out, used, and then came back into treatment. Now, they often don't make it back to treatment. So whatever your policies are regarding non-compliance with treatment, I hope you take a look at them in light of the fact that kicking people out of treatment really is an extremely dangerous step, and will often lead to the death of patients. So it's not like we're not dealing with the myth of Breaking Bad and Walter White and what we saw in the 90s and 2000s. the drugs now are much more lethal, and that's why we're seeing death rates that we've never seen before. And so I just want to make that point. If there's nothing else you hear from today's talk, other than this is a different set of drugs that are much more lethal. If you get people into treatment, keep them in treatment somehow. The goal of treatment really is retaining them in treatment for an extended period of time. Yes, helping them get into recovery is for sure a priority, but if you don't have them, if you can't keep them in treatment, they're not going to get into recovery, and they're likely to be at a very high risk of overdose death. Here's some data from, this was CDC data. This just makes this same point. Cocaine deaths more than tripled between 2012 and 2018, and methamphetamine-related deaths increased fivefold during that period. So the idea that we're seeing more deaths related to stimulants is not up for debate. We're seeing a lot more. This shows the rates of death related to cocaine, the blue line, and methamphetamine, the green line. Those lines flipped in 2020. That is, there are now slightly more deaths from methamphetamine than from cocaine. And we're expecting that because the cartels have prioritized manufacture of methamphetamine, because it allows them to be independent from the Colombian cocaine supply, we're expecting that we're going to continue to see increased amounts of methamphetamine. They can make it on their own. They don't need to have coca from South America to provide their product. It's cheap to make. They have formulas now that make extremely potent methamphetamine, and so we expect that will likely be the stimulant that predominates. And we're seeing that pretty much all over the country. And here in New England, where I live in Vermont, we never had methamphetamine before. Stimulant use was always cocaine. And now, for the first time, we're seeing far more people using methamphetamine than cocaine. And I suspect it'll stay that way for some time. The thing I think it's important to realize is that there have been some demographic differences in who uses what, and that means who's at risk for death from what. Within the non-Hispanic Black population, cocaine has been, up until very, very recently, cocaine has been the drug that has been involved with overdose death for African Americans. Other groups have been predominantly methamphetamine related, but and even now in the Black community, in the African American community, we're seeing higher rates of methamphetamine death, but still cocaine plays a role. This just shows the green line is the age-adjusted rates of overdose death, with the green line being non-Hispanic Blacks. Non-Hispanic whites and Hispanics show levels about half that much. So this was mainly in the East Coast, mainly in urban centers where cocaine was supplied by a different trafficking group than the Mexican cartels. And so you still saw a fair amount of cocaine coming in, but this is changing even in those areas to date. This gives you some idea. This was just published about a year ago in JAMA Psychiatry. This makes a couple of points. This is overdose deaths related to methamphetamine per age-adjusted rates. The blue line are American Indian Alaskan Natives. Throughout the United States, the tribal populations and tribal communities have had by far the worst death rate from methamphetamine. More than double that of any other group. The white non-Hispanics are next, and then I think that's the average 7.3, and then Hispanics. So, I mean, it's really an outlier, the death rate. If you're working in any of the communities with a high proportion of American Indian, Alaskan Natives, overdose prevention with those populations is incredibly important. They're at extremely high risk for overdose death. Al and I are doing a fair amount of work in Montana and Wisconsin and of course California, where There are very large Native American populations. Al, I think, maybe doing some work in Arizona with some of the tribes there. And they're really scrambling to try to get treatment for people with methamphetamine use disorder. We're not going to talk so much about treatment today. The next two sessions will be on treatment, but certainly as you're thinking about treatment, the American Indian population is certainly a priority group to address aggressively with treatment and harm reduction strategies. The reason that methamphetamine death rates, part of the reason that they're up so much is there's a huge amount of methamphetamine coming in. The customs and DEA assume they are able to seize somewhere in the neighborhood of 10% of the supply coming in. And as you can see, 10% is a lot, but it's, 90% is a lot more. And that's what's making it across the border. And the price is right now, the price is at an all-time low rate, that is price on the street for methamphetamine, and the potency and purity are at the highest they've ever been. And this just shows, again, the methamphetamine death rate as it's gone up over the last 15 years or so. Why are more people dying from methamphetamine-related overdose? Well, there's really two issues. One is the fact that most recently, we're seeing a lot of fentanyl in the methamphetamine supply. We've seen that in the cocaine supply for some time, but now it's being, people are buying methamphetamine and it already has fentanyl in it. So when someone takes a dose of methamphetamine, they're getting a big wallop of fentanyl. If they're an opioid naive person, that may be a fatal dose of fentanyl on their first try because they're not tolerant to opioids. The other reason is that the methamphetamine itself is becoming much more potent. This shows you back in the 2000s, this is like the Breaking Bad era, 2000 to 2004. During that time, we saw an increase in the purity from the 30s. When I was seeing lots of patients in California in the 90s and very early 2000s, the purity was about 20%. It was cut, people would manufacture it on their, kitchen stove or in their garage or in their, little home lab. And the best purity they could get often was about 20 to 25% pure. And even then they would cut it sometimes if they were going to sell it to somebody else. So you were getting a pretty low grade, low purity product. Recently in 2016, 2018, and 2020, you can see the purity is almost 100%. It's well more than double what we saw. And when you're taking this very, very pure methamphetamine, it does stuff to your brain and body that the lower grade methamphetamine, well, I'm sure it did lots of bad stuff to your body. And if you did it long enough in high enough doses, you certainly could produce substantial damage. But what we're seeing now, and it's been really clear to Al and I as we've helped the folks in Montana with treatment, the patients there are much sicker than the ones we saw in the 1990s and 2000s. And we think probably a good part of the reason for that is they're getting a much purer drug, and it affects the brain more quickly. It affects the brain more profoundly, and not just the brain, the heart, and other teeth, skin, all sorts of medical effects are much more dramatic and much more rapid. The other thing you should know is there's a term, methamphetamine potency. Now, potency refers to the actual formation of the methamphetamine molecule that you're using. There are really two forms. There's L-methamphetamine and D-methamphetamine. And what we're seeing now is back in the early 2000s, we saw probably about a 50% mixture of L and D methamphetamine. D-methamphetamine is the one that's the damaging one. L-methamphetamine doesn't really do much of anything. We're now seeing almost 100% pure D-methamphetamine, so, or potent methamphetamine. So not only are you seeing pure methamphetamine, you're seeing extremely potent methamphetamine. So it's a different ball game than if you have been were working with people using methamphetamine 10 years ago. The drug is very different and much more lethal. And that brings me back around to the same point I made at the beginning. Working with people to get them sober is what we all do, but dead people don't get sober. And so the first order of business with this population is to try to get them into treatment, try to get them into harm reduction services if that's what's available and what they'll accept, to try to help to reduce the death rate. Because this death rate really, if it wasn't for the pandemic and now the Ukrainian war, this overdose crisis would be major news, would be the most significant public health problem in the United States. But I think it's sort of gotten hidden in the COVID epidemic and other news stories. And so I don't think people realize exactly how severe it is, that in the last 12-month period we measured, which was October 2020 to October 2021, 105,000 people died of overdoses. That's as opposed to 70,000 who died in 2018. So the increase has been gigantic in proportion. And that sort of has not really been noticed. And I think there's also been a real fatigue. The American society really is really sick of dealing with, the opioid crisis, and now it's something else. But it's never been as severe as it is now. And this methamphetamine is playing a significant role. This just gives, I have a newer talk that I tried to substitute, but I didn't get it in time, showing the blip up as of the beginning of the pandemic. You can see it a little bit here. The last four dots on this graph are, I think, March through August of 2020. That line sort of takes a left turn and goes straight up as the pandemic progressed. And so you get the point. Overdose deaths are a problem. Obviously, fentanyl is playing a role. I know Florida has had a relatively lengthy history with fentanyl, and fentanyl is extremely lethal. This is the comparison of the amount of drug it takes for a lethal dose for fentanyl versus heroin. So you don't have to mix very much fentanyl into any drug, cocaine, methamphetamine, heroin, to produce a lethal dose. And that's the main reason we're seeing this huge upswing in deaths. Here's some information that I thought was interesting. This is a new paper published about 4 months ago on the perception of the people who use methamphetamine and their perception of methamphetamine. These are some of the reasons they gave for finding methamphetamine of interest to them. First, obviously, they found that it helps them, gives them energy, gives them focus, gives them confidence, makes them feel good. All of those things at the early stages, methamphetamine produces a powerful wallop of dopamine that makes you feel good and does all of these positive things. And for some people who are cruising along, doing things in life, they take methamphetamine and wow, I like this. This is a better way to live. However, for people who are not doing so well, having depression, having PTSD, having a variety of mood disorders, dealing with trauma, dealing with the pandemic, dealing with all kinds of problem areas, when they take methamphetamine, life doesn't seem so bad. So you get both. I mean, they're both the same. They're the opposite sides of the same coin. The drug makes you feel better. And that does happen when people are initially exposed to the drug. They get a positive effect. And by the way, unlike opioids, where they eventually say, well, I don't get high anymore, I just don't get sick. That doesn't happen with stimulants. They continue to get the euphoria even well into their history of use. Other things they say about it. For some, they saw it as a way of treating chronic pain. Now, this is news to me that this is useful for chronic pain, but that's what some people have said. In some of the areas where we've done, Al and I've done some work in West Virginia in particular, where a lot of people in the mining industry have, pain issues or injuries. This is a reason that was often reported there for why they found methamphetamine as being a good alternative. Often there, what we saw was there was a lot of prescription opioids. They were taking those, dealing with their pain, and then got into addiction. And then the prescription opioids went away, and methamphetamine became the way they dealt with chronic pain. This second bullet here was one that this also was news to me, that people felt that methamphetamine was a way of treating their opioid withdrawal. So they, whether they're dealing with an opioid addiction and they take meth on top of it to reduce the withdrawal symptoms, or if they've been on Suboxone for their opioid use disorder and they decide they want to get off Suboxone because they don't want to have to go to the clinic, or they don't have their insurance ran out or whatever, they'll view methamphetamine as a potential way of detoxing from a Suboxone and maybe methadone. But as far as I know, there's no evidence to think that these stimulants have much effect on withdrawal symptoms, other than, I suppose, if you're in withdrawal and you take a dose of methamphetamine, the dopamine release may be somewhat helpful, but it certainly is not a legitimate or medically appropriate treatment for opioid withdrawal. And a lot of people were introduced to methamphetamine through their drug network. It showed up in the same networks where they were buying prescription opioids or heroin. And as I mentioned, many of them started methamphetamine really without knowing it. They were, it was mixed into their drug supply. Some of them took it as part of their heroin. And that's sort of the Trojan horse method of, we'll stick it into the drug you're already using so that you get a little sample of it. That's exactly the same thing that's happening now with fentanyl, where fentanyl is put into the drug supply, and many people don't know they're taking fentanyl. Actually, now that I'm talking in March of 2022, it may be unlikely that people don't know they're taking fentanyl. They probably do now, as of right now, but a lot of them started into this stimulant fentanyl combo without knowing what they were getting themselves into. It's pretty much known now that fentanyl's in almost everything. And they'll talk about how easy it is to acquire. It, is available at, at the gas station. You can get it at, in any place you can buy drugs, methamphetamine is available, and it's much more affordable than many of the other categories of drugs. This is another study on the same topic. This was published about a year ago, perceptions of use of methamphetamine. People often were exposed to it early. In the work that Al and I did, working with people in California, people who were primary methamphetamine users, the age of first use was in the early teens, 13 and 14. So a lot of the individuals we saw who did the alcohol cannabis startup and then went to methamphetamine. In many cases, the people you're seeing in Florida may have done the cannabis alcohol startup, but then started with opioids and now have moved to methamphetamine. So slightly different trajectory, but you end up in the same places. Same kind of things, low cost availability. And in some places it has lower stigma, although I'm not sure it maintains lower stigma for very long. For example, here in Vermont, where methamphetamine has not been very available, the docs I work with in the emergency departments who are gung-ho treating people with opioid use disorder with buprenorphine are saying, where's the buprenorphine for these people with meth use disorder? We don't know what to do with them. And they come in and they're disruptive and they're psychotic and they're, we're scared the staff. And so I don't think this lower stigma lasts very long. In fact, individuals who use methamphetamine often are a fairly stigmatized group because of often the behavior that's generated by their use. As again, opioid withdrawal release, they think they can reduce their opioid use. And another one that is one of the, that we used to use the term old wives' tales. I don't think that's the right term anymore, but one of the myths, I guess, that we are now hearing is that you can use methamphetamine to reverse an opioid overdose. I don't think so. It would certainly, there's no textbook I've ever read that suggests that stimulants will reverse an opioid overdose, but that's one of the myths on the street. They enhance their functioning, they get pleasurable effects. These are all the things that you hear from them. One of the things we heard in this sample was some of them started onto their meth use when they were kicked out of treatment from buprenorphine or methadone. They were kicked out and they started up on methamphetamine to control their withdrawal symptoms. And they now recognize that fentanyl adulteration is part of the risk with that. Okay, so there's a whole salad of activity going on out there with methamphetamine and fentanyl producing this high risk of overdose death, getting people engaged in really a real swamp of drug use that produces a whole range of effects. And, what you're seeing, the population you're going to be seeing are going to most likely be using both opioids and stimulants. But it's important to know what the stimulant effects are, because once you start seeing people with a lot of these effects, they're quite different than those who are purely opioid users. This was an article published, now it's been 2 years old. It's an excellent review, A JAMA Psychiatry by Martin Paulus and his colleague. This really gives you a really good picture of the effects of methamphetamine on the brain. And I'm not going to do it justice. I will just summarize by saying methamphetamine damages the brain, produces functional brain damage. Overall, the altered brain state is consistent with degenerative central nervous system diseases like Alzheimer's and dementia. In this paper, Martin published this in 2020. The research he based this on was really looking primarily at the older methamphetamine research. And so the conclusions he comes to here are even more emphatic with the newer, purer, more potent methamphetamine. When you see somebody who comes into treatment who's been using methamphetamine chronically, they have essentially functional brain damage. And that needs to be taken into consideration. Methamphetamine affects at least these 3 neurotransmitters and likely other brain chemistry, but certainly the one we focus most on is dopamine. That methamphetamine destroys dopamine terminals, destroys the neuron's ability to reuptake dopamine. And so you really have a damaged dopamine system after you've used methamphetamine chronically. If you have a damaged dopamine system, you don't feel good. That's one of the symptoms that we see in Parkinson's disease, is a destruction of the dopamine system, thereby resulting in symptoms of depression, symptoms of cognitive dysfunction. And that's very much what we see with people with chronic methamphetamine use. One of the easiest areas of dysfunction is their cognition. They aren't functioning properly cognitively. Some poor performance on a variety of tests in early recovery, and after prolonged abstinence, you also see significant deficits in their functioning. 2/3 of those show significant cognitive impairment. I would guess in the current situation, it's more than 2/3. If anybody's been using methamphetamine chronically, they're very likely to have significant impairment. And it's associated, if you're older, if you've used longer, if you inject, and if you use multiple times a day, all of it's going to be worse than. So there's a real direct relationship between how much you use, everything is worse with injection. If you inject methamphetamine, your overdose death risk is much higher. Your cognitive effects are much more severe. The effects on your cardiovascular system are much more severe. So when you're working with the population in Florida that you're seeing, if a lot of them are injecting, and a lot more are injecting now than used to when I was seeing patients. When I was seeing patients in California, it was about 3/4 smoking methamphetamine, and you'd see 10 to 15% injecting. It's much higher now because many people now have come through the opioid addiction, where many of them often started injecting and they just switch over to methamphetamine injecting. That's a bad thing that's happened, and that's part of why we're seeing so many deaths and so much more impairment. The last point is, recognize when you're working with these folks, their brain isn't working correctly. If you're giving them directions for treatment recommendations, it may not register. They may not understand what you're telling them. They may nod their head, but they may not be understanding it. And even if they do understand it, they may not remember it for very long. So, you know, it's important to recognize the impairment these folks have. Other impairment you see strokes occurring. It was pretty rare back in the 80s, 90s to see people who were in their 30s and 40s having cerebral strokes. Not at all uncommon now. The strokes are both brain hemorrhages, where the blood vessel in their brain bursts, usually because of very high blood pressure from methamphetamine effects, or the blood vessel will constrict and be blocked, and they'll have a stroke that way. So it's important, if you're working with this population, to learn about the signs of strokes, because they're not unusual. And, you know, as I talked to my emergency department colleagues about a couple of days ago, they've never seen people in their 30s and 40s coming in with strokes before, and that's not unusual with the current methamphetamine supply. Similarly, cardiovascular disease. This methamphetamine has very direct damaging effects on the heart muscle. You get pulmonary hypertension, arrhythmias, damage to the heart. You get endocarditis with injection. You get infection of the heart valve. In San Diego, where they've seen methamphetamine for many years, and it's sort of ground zero for the methamphetamine problem. In some of the hospitals there, they have whole units set up for treating endocarditis of patients who got it via injection of methamphetamine. So this is an area that often the health system isn't really ready for. I'll skip through this. It just makes the point. There's lots of strokes. Pregnancy. We've spent a lot of time in the last 20 years with methadone and buprenorphine and prioritizing getting pregnant women into treatment and getting them on medication. Well, with methamphetamine and cocaine, we know these drugs, when used by pregnant women, have an effect on the woman, on her pregnancy, and on the unborn child. Some of the things we've seen from this was a meta-analysis. They looked at 31 studies of cocaine use during pregnancy and found that there was increased risk of preterm delivery, low birth weight, small for gestational age. So smaller babies born to mothers who were actively using cocaine during pregnancy. Similarly, 8 studies with methamphetamine use during pregnancy, again, earlier gestational age and lower birth weight, and also smaller head circumference. You really see when you're comparing the cocaine and methamphetamine stuff, you tend to see a lot more structural impacts on the body and the brain with methamphetamine than with cocaine. Cocaine certainly does plenty of damage, but I think it's particularly because of the current methamphetamine is such a toxic, potent drug that we're seeing much more medical damage than we saw in the past. The babies born to mothers who are actively using methamphetamine often have a more severe withdrawal, and both drugs are transmitted or excreted in breast milk. So if the mother continues to use post-delivery, she shouldn't breastfeed because the baby will be given, the drug will be passed on to the baby. Number of studies have been done on the effects of methamphetamine on the children who were exposed during pregnancy. This was a big multi-site study that we were part of, run out of the University of Hawaii. At 3 years old, those kids who had been exposed prenatally had elevated levels of anxiety and depression and a much higher rate of attention problems. At 7.5 years, we saw poorer cognitive function in those kids. We did a separate study. We looked at 4 to 5 year olds, and the thing we found that was really dramatic was much poorer fluency with language acquisition, that is the number of words that they that they used, and their fluency in expressing themselves in other ways. Their vocabulary was more impoverished. So the effects of this certainly are multi-generational. Dental problems, people with substance use disorder in general tend to have fairly poor dental habits. Methamphetamine produces some effects that make that even worse. Of course, they have, generally have not good dental habits. They have lots of cavities and they have a high sugar diet. And so they get lots of damage to their teeth that way, periodontal disease. But they also, methamphetamine reduces saliva output. Methamphetamine use reduces saliva output. So they often will have a dry mouth, and that sets your teeth up for being more likely to have cavities and infections. They grind their teeth, bruxism. Somebody on methamphetamine, certainly during a long run of use, will be grinding their teeth. If they do get to sleep, they often grind their teeth, and that does a real lot of damage to their teeth. The methamphetamine, there's some debate about whether when you smoke methamphetamine and you bring it into your mouth, whether the actual effects of the smoke itself are damaging. Just suffice it to say, if you're providing treatment for people with methamphetamine use disorder, it's really important to get them into dental treatment, because often they haven't been aware of the pain that's involved from their dental cavities and all the other stuff. Once they stop using and they don't have the drug effect, they're in significant dental pain. That often will take them back to using if you don't get that addressed right quickly. This is a study we did on dental disease, but it's one of those great studies. We did this extensive study and we pretty much proved, which most clinicians knew already, people who use methamphetamine have lots of dental problems. Dermatologic effects, you see significant scratching, digging that the individuals who use meth will do, because the drug constricts the blood vessels near the surface of the skin, and it makes it feel itchy, and they'll scratch it, and they'll scratch their torso and their arms and their face. And if they're using heavily in long runs, and they start becoming psychotic, they'll often think they have bugs under their skin, and they'll start digging them out and thinking that they've dug out bugs under their skin. We've actually had patients bring in little glass jars of water with little flecks of skin that they're convinced are bugs that dug out from themselves. If they inject, their injection sites typically can be more severely medically concerning with cellulitis and infections of their injection sites. And of course, if they smoke, they often have burn injuries to their mouth, lips from hot pipes if they're smoking. We did this a paper I did back in 20 years ago now, and I'm not quite sure why this has never been followed up in more detail. We found that we looked at we were running clinics at the time. We had lots and lots of patients. And we took a group who were predominantly there for alcohol use disorder treatment, and another group that were there for opioid use disorder treatment, and a group there for cocaine use and methamphetamine use. So we had 4 groups of patients, 100 in each group, half men and half women. And we gave them a whole bunch of questionnaires about their sexual behavior. And the short answer is anything to do with sex is much greater with people who use methamphetamine than any of the other categories. With cocaine, you see high rates of sexual behavior with men, not so much with women. With methamphetamine, you see it with both. And just about anything you could ask them about, amount of sex, duration of sex, the sex drive, you name it, it's greater with methamphetamine. So it's an important clinical issue. Lots of places when people go into treatment for methamphetamine use disorder, nobody ever talks to them about their sexual behavior because it's, if you're a therapist, it's, can be challenging. And when Al and I were seeing patients, one of the groups of people we hired to be counselors were interns, and we had in that group, there were a lot of younger women. They were uncomfortable talking to these males about their sexual behavior, understandably. And so, but it's an important issue, and I certainly would recommend finding a way to appropriately address this in clinical populations, because for many of them, once they get into recovery, they go from this sexual, circus that they've been in to no sex. And in many cases, for many of the men anyway, they can't function sexually. They can't sustain an erection, and their sex drive drops off. They're not interested in sex, and it becomes a big part of their thinking space. And if nobody is talking to them about it, often the scenario becomes, well, I was doing everything everybody was telling me, but I thought, if I'm never going to have sex again, I can't live the rest of my life like this. And so, relapse justification. Okay, here's some of the short-term management issues. This was data from an emergency department in Brisbane, Australia. And the point this makes is that in the emergency departments, this would really need to be updated. I would suspect now, if you looked at this, the number one rated clinical effect, maybe in fact overdose. Not so in Australia, and certainly not in 2016. Behavioral disturbance. People who use methamphetamine often come into the emergency department because they're psychotic or acting, or they're intoxicated and are, out of control, running around saying things that don't make any sense. And they have the potential to become violent. Certainly working with individuals who have methamphetamine use disorder, it's important to know strategies for de-escalating someone, because often they're going to be, amped up, going a million miles an hour, not thinking clearly, having paranoia and other forms of psychotic thinking. And if they're confronted, they can become violent. There's data on that. They have a higher risk of violence with methamphetamine, but it's all when they're intoxicated or psychotic. It's not, under their normal conditions, they're no more or less violent than anyone else, but in those conditions, they can be. In terms of addressing the acute psychosis, we don't have specific protocols, but mainly the same approaches are taken if a person is acutely schizophrenic and comes in with psychosis. Now, the psychoses themselves the symptoms are quite similar, but with methamphetamine, generally their psychosis will go away within 8 to 12 hours without medicine, if you can put them in someplace quiet and they'll stay there. Often antipsychotics are used sort of just as big tranquilizer darts to slow them down, to keep them from hurting themselves until the methamphetamine is metabolized out. Now, there is the case of some patients maintaining a chronic psychosis. That is, the methamphetamine triggers the psychosis, you wait 8 to 12 hours, and the psychosis continues. That's pretty rare, but we have seen in our experience of treating people with methamphetamine use disorder, chronic methamphetamine use appear to precipitate a chronic psychosis, even after their meth use has stopped. Rare, but it does happen. Intoxication is they have euphoria, they're hyperexcited, increased moving around, they're agitated. They can have some psychosis, and even if they're not psychotic, they have a lot of paranoia. Paranoia is a real hallmark of people with meth use disorder, and we'll talk about this when we get to the treatment discussion next session. This paranoia makes getting them into treatment even more difficult than would otherwise be the case, because they're paranoid. And talking them down, again, de-escalation, getting them into a quiet place. In some places, if they're very severely agitated, short-term benzodiazepine use may be necessary, but it's, in general, this will pass within 2 to 4 hours, this intoxication effect, if they just stay quiet and don't hurt themselves. Methamphetamine withdrawal, this was the first paper actually published on this, was published about a little less than a year ago. And what they found is the withdrawal from chronic methamphetamine is characterized by depression, fatigue, sleep disturbance. Once they wake up after they've slept for a while, increased appetite, and they do have ongoing anxiety and depression. And this can last for up to 4 weeks. So those who have chronically been using, you're going to be more likely to see this. Again, this is related directly to the amount of use. The more they've used, the more recently they've used. If they use by injection, you're much more likely to see this withdrawal than if they've used other ways. I just wanted to put this up just to give you some idea of what population of individuals who use methamphetamine, what their use pattern looks like. Drug use in the last 30 days, they've used methamphetamine on average, a median of 173 times. So 6 times a day in this group. And of those, 2/3 of those were injections. So I don't know if it's 2/3 of the people were injecting, or if the people injected, if the 100% of the people injected 2/3 of the time. I think it's more likely the former. But you get the point. They're using a lot, they're injecting a lot. And so when you're seeing these folks, they come in pretty severely impaired because they've been using a good deal of the drugs. And the people who with injection drug use tend to have the most severe withdrawal. The anxiety and depression can be quite severe as they go through this. As far as the treatment goes, there is no methadone or buprenorphine to treat their withdrawal. Sleep, diet, rest, exercise, moderate exercise at first and more exercise later on can be extremely helpful. You may need to give them some help with sleep, but then again, you have to be careful given the abuse potential of some sleep medications. Okay, so that was the first round of me jamming a bunch of information at you on the effects of stimulants. There's, of course, a lot of other information, but probably the take-home points are, A, we're in a world of the type of methamphetamine and the combination with fentanyl where these drugs are incredibly lethal. And if you can get people into services, whatever the services, harm reduction, treatment, outpatient treatment, even if they're not doing it perfectly, if you've got them coming back, if you can keep them coming back, their risk of dying is less. This can often be a big challenge for treatment programs who are abstinence oriented, as most are in the United States, because the idea that you have people coming in who are actively using is not how it's supposed to work, at least not in your mind. But for the user, for the individual, the population that we're seeing now, the reality is these people are at very high risk to die. And if our first priority isn't to keep them alive, then, you know, I think people may want to consider another career if you don't get that. So finding ways, different tracks, coming in during different hours, seeing different therapists, coming to a different site for people who are maybe not doing perfectly but are trying, as opposed to the patients who are really robustly working on abstinence. That may be something you want to do. So that, I think, is important. Secondly, these folks have a lot of medical problems, and they're dangerous medical problems. They're not insignificant medical problems. They're strokes, they're heart attacks, they're infections to their heart, they're infections through to their injection sites, and those really need to be taken care of. Again, Al and I, the treatment program we ran, Matrix in California, was basically a counseling program. We did a lot of CBT and other kinds of behavioral treatment. We didn't really do that much in the way of medical care because our patients, you know, some of them we should have gotten more involved with medical care. But now, 20 years later, the idea that we're just going to work on their drug use and we'll put blinders on and we won't really worry about the rest of their medical risk, that really is not conscionable, I don't think, anymore. I know it's a challenge. I know billing and financial issues are problematic with regard to that. But I do think if you're treating the whole person and you want to keep this person alive and help them get into recovery, you know, if they die of a heart attack or if they die of a heart infection, they're just as dead as if they died of a drug overdose. So I would certainly keep that in mind. And as far as the treatment of them at the front end, when they come into the treatment system, they're often psychotic, they're often agitated, they're often not thinking clearly, they're often depressed. And as we'll talk about in the next session, they're not particularly interested in treatment. I'll probably repeat this tomorrow, but when we do a lot of training, we've done a lot of training with young therapists for years. And one of the lines I love to hear is when somebody raises their hand and says, you know, I really love working with this population, but I really only want to work with the motivated ones. I don't really like working with the ones that are not motivated. I usually say to them, I really think you should look at a different career path, because this is if you're thinking you don't want to work with people who are ambivalent or not interested in treatment or don't want to get fully abstinent, this is not a good group for you to work with, because this is the nature of this population. So I'll stop there, and we said we would leave 15 minutes for questions, and so we'll see if you've got any questions.
So I have one directly to me, Dr. Ralston, which was, can cocaine use induced AFib resolve itself after stopping?
Cocaine related afibrillation, is that what the AFib?
I believe that's what they're referring to.
Yeah, you know, I can review these studies and review the papers. I'm not a physician. And so that would be a little bit beyond my, uh, you know, pay grade. My understanding from talking to physicians and having done lots of panels with doctors is most of the effects with these stimulants are transitory and will go away if they stop using. And that's what we've always told people, and getting them into recovery. If you get into recovery, a lot of this horrible stuff that's been going on, including the medical stuff, will get better. But I do think it's, you know, becoming almost essential to have a physical exam as part of treatment for a substance use disorder, because these drugs are so potent. And the answer to the question is, first, A, I'm not qualified to answer it. B, I think that's the case. But C, you should probably get a consultation from a physician who could better answer the question. Other questions?
I see one that I believe you should have gotten as well, Dr. Olson, that is specific to youth that are addicted to meth, etc. Are there any specific journals or studies on success rates and or challenges with dual diagnosed youth?
Great. That's a great question. My colleague, Rachel Gonzalez at UCLA, is one of the few people that's done much work with youth who use methamphetamine. As far as I know, there are no good studies on specific treatments for this population. Rachel's work is using app-based communication, mainly for continuing care for youth who have gone into residential treatment for meth use disorder. They go through some kind of residential care. And then she's been using an app-based communication system to maintain them in their continuing care. Her studies have been, her first couple of studies have been quite positive in keeping them, because youth, obviously, they live on their texting devices, and she's found that as a good way to augment the rest of the continuing care. They get the in-person stuff. But really, I have to say, this is an area where we have very little research to guide us. California, we're doing a big project with contingency management using incentives, and we're setting up a whole separate program of that for youth to use incentives to keep them, to help them get abstinent. But it's an area that really requires could use some good research. I don't know of any good journals specifically, but I'll send Rachel an email, and if you send me your email, Marcelina, is that who I see? If you send me an email, my email is on the screen, and asking for information, I'll forward it to Rachel and see if I can get you Rachel's most recent information, because she's always writing review articles and stuff like that on youth and methamphetamine. By the way, that was a guest appearance from Alpha, my cat, who I just got a kitten yesterday, and the kitten is in Alpha's room, so he's roaming around meowing. So I apologize for him, but he wanted to say hello. Any other questions?
I do not see any others at this time in the chat panel. If anybody else has any other questions, of course, you can send them to Dr. Olson, as he said. I'll give it just a second just to see if any have come through.
Very good. And as you know from the schedule, tomorrow we talk about sort of what the evidence-based treatments are that are currently available for treating people with meth use disorder. And on Thursday, Al will be talking about a combination of evidence-based treatments that we've put into a protocol that some people are using in around the country. But okay, then we will enjoyed talking with you, and we'll talk again tomorrow.
Well, thank you so much, Dr. Awesome, for all of your information that you've given today and shared. You did a great job, everybody in the chat saying great job and great information. So thank you again for doing it again a second time. And
Very
just
good.
as mentioned, today is part 1 of the series. We will pick up again tomorrow at 2 p.m. With the next part of the series. And just please, a couple items of business before we conclude today's webinar. There is a link in the chat panel to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADAA's website. If you want to receive CE credits or statement of credit for this event, you must complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, please make sure you have included an accurate Florida Department of Health license prefix and number when you register. After you register or sign in, you'll be directed onward to the evaluation. You must use the same email address you used when you registered for today's webinar as what you have on your FADAA account. If that is not the same email address, please make sure you update it. That is the way we connect your attendance to this webinar with your profile so that you can receive CE credit and statements of credit. You will get a second opportunity today to complete the evaluation through a follow-up email. The sender will be messenger@webex.com. Please remember that the evaluation closes Friday, March 25th at midnight. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. If you're not sure how to locate your journal entry within your profile after 30 business days, you can go to our website and we have a frequently asked page where you can get information on how to view your statement of credit. And thank you again for participating in today's webinar. We'd like to recognize and thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and thank you again for joining us. See you tomorrow.